For everyone with an interest in MASH, or more broadly, steatotic liver disease, Surf's Up, Season 5, Episode 23 of Surfing the MASH Tsunami. Our look at patient-physician communications starts now.
This week on Surfing the MASH Tsunami.
So the greatest opportunity to create motivation for lifestyle modification is the interaction between the physician and the patient. This is the greatest opportunity, which is often missed.
I remember that I said to a doctor 2 years ago, you don't listen. And he said, yeah, I hear you. I said, yes, I see that, but you don't listen. That's something else. And he was really in shock.
At the beginning, it's like speed dating. You've only got a few minutes and you've got to nail it. And because you're going to face the future relationship you have with one of the biggest people in your lives for the next 20 or 30 years, particularly in the speciality of hepatology, on a 4 or 5 minute interaction.
Tom, you said that if a patient actually said to you when they're having a discussion, their consultation, that what you said to them really hurt them or made them feel bad, you said you would learn more in that moment than you would learn an entire weekend at a Stigma workshop. And to me, it was like it blew my mind.
Yeah, sometimes don't think we as doctors really realise, or we need to keep reminding ourselves just how big a deal that consultation over the next 20 minutes is for that patient. And it's a much bigger deal for them than it is for me.
Last month, over 7,000 hepatology stakeholders convened in Milano for the EASL Congress 2024. This week, join liver wellness advocate Louise Campbell and her guests, hepatology researcher and key opinion leader Shira Zelber-Sagi, UK physician Tom Marjot, and patient advocates Willemse and Mike Betel, as they discuss a pivotal session on patient communication challenges that was presented at the Congress. This week on Surfing the MASH Tsunami.
Remember to keep listening after the episode for this week's question of the week, sponsored by Madrigal Pharmaceuticals.
Hi, it's Roger. When we arranged for this week's episode, we did so by finding 4 people who were panelists at an extraordinary session on patient communication and challenges. The first day of EASL, actually the day before EASL in Milano last month. And Mike Betel and Shira Zelber-Sagi, who co-chaired the session, and Tim Marjot and Jose Willemse, neither of whom had been on the podcast before, who had a rather exceptional dialogue in the middle of it that triggered Louise's interest in the episode. So we put out a doodle to find out when we get everybody together, and the one time during the recording span that we could get all 5 together, the 4 panelists and Louise, the person who couldn't make it was me. Well, I've always contended I'm the least important person on this podcast anyway. So Louise is going to moderate this session. You'll hear it, and the only thing you'll understand about what I am frustrated about is I'm frustrated I didn't get to be there. It's just superb and really inspiring. So have fun. Listen to Louise and the team, and I'll be back with the question of the week and business report when it's all over. Thanks.
Just for everybody now, obviously Roger is not here, and I get to play, as you all know, when Roger is not on the podcast. So this week we're doing the patient challenges in navigating healthcare. Now, this came out of a very interesting session and exciting session at EASL in Milan recently. It was the first session on the first day. It was co-chaired by 2 of our guests, Michael Betel and Shira Zelber-Sagi, and they did a wonderful job. And we've got 2 of the presenters here, Jose Willemse and Tom Marjot, who presented on both different aspects of what a patient wants to know and desires in a patient face-to-face interview, and what a doctor thinks a patient wants to know, what the doctor wants to know, which was an extremely entertaining session, having been in the room. But the enthusiasm coming out of that room was amazing for the first session, first day. So congratulations to both Michael and Shira for doing that. So I'm going to ask Jose and Tom, as new surfers, we always ask you to share a little bit about yourself and what your role is and what you do. And also then I'm going to ask you to end that with telling us one fact about yourself that nobody else would know or would be unusual if you didn't tell them. So first one, go first. Who you can choose whichever.
Well, I jump in. It's so good to be here, and it's great to be a surfer. It sounds like I'm officially a surfer, which is great.
You are officially a surfer. Welcome.
So my name's Dr. Tom Marjot. I'm based at the University of Oxford in the UK. So I'm a clinician. I'm a clinical academic. We've kind of 2 hats on, really. The first is very much as a day-to-day hepatology doctor, helping run a busy multidisciplinary MASLD clinic in a tertiary referral centre in the UK. And then the other 50% of my time is doing clinical research, mostly in metabolic disease and MASLD. And great to have contributed to the patient advocacy session at EASL Congress, and great to be invited back to talk about this a little bit further. And then now it's my time to reveal something to you. Is that right, Louise?
Depends on what you're revealing.
Yeah. Let me just filter what's appropriate for the podcast. I like being centre of attention. I think the best way to achieve that in day-to-day life is through karaoke. So I think it's quite difficult to get me off the karaoke stage from doing Elton John and Freddie Mercury and Billy Joel. I keep advocating at the various committees that I'm on. I think there should be more karaoke at hepatology conferences. Maybe that's something we can all lobby for going forward.
I think you've got an invite to a Japanese conference straight off.
Yeah, maybe I should go to a puzzle. You're right. But yeah, so that's me, and great to be here and looking forward to further discussion.
Fantastic. And Jose?
Yeah, hi. Well, I'm happy to be here, and it's very exciting to meet Tom again because we had a wonderful session at the first day of EASL. I am a patient advocate for over 25 years and the last 10 years in the liver world. And when I started, so in December 2013, they phoned me that I had the job as the CEO of the Dutch Liver Patient Association. I called one of my good friends, and he is a doctor. He's a professor now for people with diabetes, and he said to me, keep an eye on, at that time, NAFLD, because that's really a new kid on the block and it will be booming business in 10 years. So, well, now we're here. And I always did. And that was the time that Hep C was really in everybody's focus. But I don't know how it happened, but suddenly people ask me as a patient expert in all committees and groups for what we say now, steatotic liver disease. It's almost a hobby. And if it wasn't so serious. So I spent a lot of time with that. I'm retired now for 2 months. But, the only thing that changed is that I can start every day now, like a Saturday, with coffee and a newspaper. And EASL keeps me busy and other groups because they say, well, now you have all the time in the world. Well, that's not true, but okay. And I have a guilty pleasure as well. I bring that every Congress with me, and that is I love to do some embroidery. And I go with just the colors, and when it's finished, you have to throw it away. But a friend of mine said, give it to me, because she's an artist in wall carpets, the carpets for hanging on the wall, and she cut my products in pieces and made it there. So, and that's fine. And so, but nobody knows. This is really a secret because nobody knows that I've always with me to relax a little bit and in the hotel room. Yeah.
Well, it's now a secret that's shared with about 135 countries where the podcast reaches and our numerous listeners, but keep it under your hat, listeners. Thank you very much for that. So I'm going to ask everybody here now to share their good story for the week, positive story, the professional or personal that they had over the last week. And brave one, go first, as Roger would say.
I can go first.
Come on, Shira, let's hear it.
So I'm not a new surfer, but I'll present myself very shortly. So I'm Shira Zelber-Sagi. I'm the chair of the Public Health Policy and Advocacy Committee of EASL. I have the pleasure to be working and keeping busy, Jose. And I'm also a chair of the School of the Public Health in the University of Haifa in Israel. And my happy story for this week is that I'm stepping down from being the chair of my department. I finished a 5-year term, and my team gave me a surprise party yesterday. And it's amazing. It's a mixture, it's a little bit sad to be stepping down, and it's also very, very super happy about it. Admit all this responsibility and then making time for other things to do, like EASL public health activities. So I think that's the best story of this week for me.
Yeah, congratulations, Shira. That's great.
Congratulations. And you will have more time to enjoy as well, I hope.
Absolutely. I hope that's my plan.
Can I just ask, is it a fixed 5-year term or was that a choice?
Yeah, it's a fixed. You don't have a choice. It's actually 2 terms. It's 3 years and 2 years. And I think it's very good that you know when your term is ending and you don't have to debate on it.
Maybe they should introduce that for the presidential elections.
Exactly.
I'll jump in next because I'm on. So England, despite everything that we've been saying in the recent podcasts, because if anybody knows, Roger and I discuss football a lot, England have made the semi-finals of the Euros. So we play Holland tomorrow night, and France, who have not scored a goal in open time, have managed to make the semi-finals against Spain tonight. So it could be anybody's. And I said last week that you don't need to be the best manager, but you might need to be a lucky manager. So Gareth Southgate. So my positive of the week is still England are still in the Euros despite everything that we've been trying to do.
It's coming home, Louise. It's coming home.
Don't say that, because we always lose it when somebody says that. It's going to enough different homes, so therefore we might win. But fingers crossed.
Touch wood.
I can go next, Louise. And thank you for having me with all these esteemed guests today. The topic is really, really important. And as I shared with you before this on the Global NASH Council, was actually a discussion point today as well. So it's very important to understand the relationships and the challenges between physicians and patients and what happens every day when they meet. So thank you for that. For me, it's been fun. It's July and things get a little quieter. So every year I do this 30-day glucose challenge thing, and I'm wearing a Dexcom G7. So I get to watch the different foods that I eat and the impact that I have. Big surprise was my son wanted to go for an acai bowl, and I went from like 100 to 225. And so it's like, okay, probably something I just have to eat. Maybe I should have shared it or something.
Taking it off.
I know the added honey on top probably didn't help either. But funny enough, because one of the people who, if you look at the comments, who follows, who I know well, said that one of her friends actually owns the whole chain. I had no idea. So they're going to invite me back to have a healthy option or healthier option. Anyway, it was just a funny story, but I keep getting surprised by what I thought was okay to eat that's not. So
Jose.
Oh, go on, Jose. Go on. What have you got?
Okay, some professional thing is that this week we started with an EASL initiative, very good, about the new steatotic liver disease, because there's a lot of recommendations around the world and plans, and we really want to make a guidance document for all countries that you have some similarity all around the world about what is our focus, what is important, and things like that. And I'm very thrilled about that, because at the end that will help the patients, because there are a lot of questions for patients, and we know that even in one country, in one city, and in one hospital, there's a difference between what the information is and what the plan is. So I'm very thrilled about that. And just this afternoon I spoke my nephew. He is 26 years old, and he don't drink that much. I don't know what that much means, but that's probably much more than I would say that much is. And it's very difficult for him, because he is working at the festivals that's all around Europe. But he knows that I would love to hear that he don't drink so much. So that was very funny, because I think that he still does, in my opinion. But that's fine. It's his life. But that young people are aware of that, that's really a bonus for me.
Shall I go last, Louise?
Yeah, you're last up.
I'm last. I've had a kind of a landmark week, because my firstborn daughter is 11 months and she's just started nursery yesterday. So first day at nursery. So I've had to learn very quickly this whole new rigmarole of get up, out the house, drop off, to work, and then also the phone call halfway through the afternoon saying that she's got a temperature, can you pick her up? This whole new world is now open to me, which I'm having to contend with very quickly, but it's been exciting but also hard work. So that's been my last couple of days, and I suspect it's going to continue for life.
For the rest of your life.
A number of years, and you'll be the taxi as she gets older.
Yeah, exactly. And then she ends up going to the festivals
and telling you she doesn't drink a lot.
Exactly. Yeah. I can see.
My children are exactly the same. And on that wonderful note, let's get into it. So the topic for today did come out of the Patient and Advocate Forum, which was patient experience in the clinical settings, that was run by Michael and Shira. So Michael, Shira, bring us into where you started with this and just the general session, and then we can move on into discussing the real effects on patient challenges in healthcare.
So in Milan, in the last EASL conference, we had a fantastic Patient and Advocate Forum discussing the patient experience in clinical setting and unmet needs. And this is actually one of many activities that EASL is doing within the collaboration called EASL Patient Synergies. So a couple of years ago, EASL decided that he wants to work more closely with a patient organization, patient representatives. And we started to work on understanding better by working with the patient, trying to understand better their experience in clinical care, thinking about patient-reported outcomes, thinking about patients' quality of life, trying to better understand what are the needs of the patients from healthcare professionals, improving the dialogue between healthcare givers and patients, and of course, eventually together to promote the prevention and the better treatment of liver disease. So actually, the Patient and Advocate Forum is one of these activities that we're trying to do together. And this year, it really worked, I think, better than ever. And I think the reason is because we managed to develop a very interesting and fruitful and open dialogue between patient representatives and physicians, and really trying to understand what are the unmet needs of the patients and what are also the opportunities of physicians to improve the patient experience, the care that is given to the patients, the communication between the patients and the physician or the healthcare providers. And also, of course, we covered also many aspects of stigma and communication. And I think that these are the things that turned this session to be so interesting and successful. So I'm really happy to get the opportunity to further have these discussions with you today.
I will add to that, and thank you, Shira, that was a great summary, that it's so important for physicians, I'll start on that side of the equation, to understand what it's like for patients when they come in and how afraid they are. And I'm taking this away from the talk too, that for them to have the courage to share with the physician how they're really feeling, often they're not. And then because the physician is looked up to so much, they're either afraid to say something or they don't think they know enough to say anything, so they don't till they get home. I have to give an example to start off. Maybe you can start off the discussion that way, because Shira talked about the stigma, and what I was left with out of the entire talk that I still remember, and I've told many people about already, is Jose was giving an example of being in the doctor's office. And then Tom, you said that if a patient actually said to you when they're having a discussion, their consultation, that what you said to them really hurt them or made them feel bad, you said you would learn more in that moment than you would learn an entire weekend at a Stigma workshop. And to me, it was like, it blew my mind. I said, oh my God, that is so insightful.
Yeah, I felt the same, Mike, exactly. I remember this exact sentence, and it was so impressive.
Yeah, I'm glad that stuck with you, Mike. I really do mean it. Changing stigma and addressing stigma is kind of happens on three levels, I think. There's the kind of very top level public health thing, which is, about policy and government level policy and decriminalization of illicit drugs and branding of disease and nomenclature. And then there's the patient advocacy level, which is trying to collect patient voices and advocate strongly on behalf of them. But actually, I think the last level is the direct patient to doctor interaction that happens. And it can be so meaningful, and it allows you to change your practice absolutely immediately. So if you had a patient number one in clinic who said, actually, I prefer you to reframe the way you explain that in this way, or actually that terminology isn't quite as good, then patient number two comes along and I can immediately make a difference. So I think it's very powerful, but the barrier is allowing patients the time and freedom to voice that to their clinician, which I think people find hard. Josie, I don't know what you think. Josie, are you telling your doctor off very much?
No, yeah, and I think you're totally right. But the problem for the patient is that, they don't feel that free to say something against their doctor because it's their doctor. And despite all the theories we have that patients, are especially in the Netherlands, they know what to say and they don't feel shy to say, if it's concerning a doctor, they're afraid to ask the doctor what they really need, or to say, hey, I'm not happy with that. And doctors are not used to those patients as well. I remember that I said to a doctor 2 years ago, you don't listen. And he said, yeah, I hear you. I said, yes, I see that, but you don't listen. That's something else. And he was really in shock. And I think that he will never forget that. But a lot of people don't dare to ask them, the doctors, like the examples I gave, had that because doctors are verbally very strong to patients. And I always gave the example that people don't feel, and this is what patients told me, because I always say, my job is very easy, I tell your stories. And they said, I didn't feel well, but I had the appointment and I thought, then the doctor will tell me what's going wrong with my liver, because I really feel horrible. Came to the doctor, and the doctor said, oh, well, I'm very satisfied. It's going well. Yeah, but doctor, I don't feel well. Oh, sorry to hear, but it's not your liver. And so the patient left the room completely frustrated and still feeling horrible. And instead of that doctor saying, hey, I don't think it's your liver, but let's see what can we do about it. Can tell me a little bit more. And it costs 1 minute extra.
I remember you saying, Jose, in coffee after the session, we had a catch up in coffee, and you told me you like it when the doctor turns off his computer screen in the clinic room. And then adjust the whole body language. And that really stuck with me, because I think in order to really address the problems of patients, you need to really focus and dedicate time within the consultation without distraction. The turning off the computer screen, one, doesn't distract the doctor, but also is kind of quite a nice signal that this is the patient's time. So I've started trying to do that, Jose, you'll be pleased to know.
Oh, well, I'm really happy to do. No, I know a Dutch doctor who does that. He always say, well, we do first my part, and then we go back to you. And so he said, oh, okay, now we are done. And, well, really put the screen away and say, well, tell me, how do you feel today? And that makes him very popular at the moment. But it's really so helpful because people really, you want that your doctor listen to you. Because I don't think our doctors realize how important they are in the life of patients. It's part of their life. You are depending on your doctor, and it's really a part of their life. And if your doctors, well, just send you away, because that's the feeling that patients very often have. And of course, they are good doctors. But this is really the main issue. The doctors are not aware how important their whole attitude is to a patient without saying anything.
I have a question for Tom and Jose, if that's okay, Louise. You're very busy, Tom. You obviously, when you have your clinic days, you have them all lined up back to back to back to back to back. Do you find that sometimes you don't have the time to look at the patient's chart before the patient is sitting in front of you? That's my question to you. And Jose, do you find sometimes you've gone to the doctor and it's like they didn't even read your update until they're sitting in front of you, and that makes you feel that they didn't care enough to prepare for the meeting with you? I just want you guys to discuss that.
Yeah, I think it's really good questions about the dynamics of a consultation in clinic. So I tend to look through all the patient's notes before they turn up in the clinic room. I think it's nearly impossible to run a sensible and safe consultation unless you've done your homework, even if that's kind of 10 minutes of flicking through the notes, where they are in the patient journey, what disease stage there are, what treatment. So I feel like I've tried to do my homework. And so when the patient arrives in the clinic room, I kind of know from a medical perspective what I'm looking to tackle. And that's good because you're trying to keep the patient safe and kind of keep the flow of the patient's journey, but you need to be careful that you don't then go in with preconceived ideas about what you want to fix and what you want to tackle. So you need to have yes, you've got an agenda about what you think you need to do, but I think you need to have the awareness and the flexibility to be able to adapt and prepare within the consultation, because Jose may come into the clinic room with a completely set agenda. And the other point I would make is that I've looked at Jose's story for 10 minutes, if that, 5 minutes before she turns up into the room, and then we go for it. Whereas Jose has got up in the morning, she spent the whole of the day before preparing what she wants to say. She's kind of got up early, she's navigated the traffic, she's waited in the clinic room, waiting room for half an hour longer than she should. She's rehearsed what she's worried about. She's rehearsed the questions that she wants to ask. So it's a much, much bigger deal for the patient than it is for me. And actually, I sometimes don't think we as doctors really realize, or we need to keep reminding ourselves just how big a deal that consultation over the next 20 minutes is for that patient. And it's a much bigger deal for them than it is for me.
Oh, wow. It's wonderful that you bring this up, because that's true. That's true. As a patient, you know some weeks before that you have to go, and then you start to okay, what do I feel? Is there something that will change? I'm curious about my test result and things like that. I'm happy to hear that you prepare the visit of your patient, because I know a lot of doctors, or they give the impression at least that they don't do that. So they start to read when you are sitting against them. And that's why they always focus on their screen and not to you, because they have to look at that. And my biggest thing is that I think, skip that sentence is that they say, yeah, I know what you want, I know what your vision is, but you know the time, we don't have time. Stop with that. You could do 5 other things instead of complaining about that you don't have time. I asked one of the Dutch doctors, have you ever asked your patients, hey, the whole list of test results, have you seen those already? And do you have questions? Because very often they do. And are there things that you want to discuss with me? And he said, well, to be honest, I never do. I said, well, please start with that. Your patients will be very happy with that. So it's also a focus. It's a mindset just to change that. And as I say, for a patient, it's so important that you ask about, and that's my new mantra, as you know, just ask once a year, how does it affect your life? Patients are thrilled about that question. It doesn't need every 3 months, but just once a year, or how are you doing today? And if a doctor can ask that question, and patients don't need half an hour to explain that. I don't believe that.
I think the time thing is interesting because I do feel the time pressure acutely in these consultations, but the first thing I agree with you, patients don't want to hear that you're stretched for time. So I think, I don't think vocalizing that within a consultation is productive. So I think the time pressure element shouldn't be part of the consultation once you're in the room. But I think what the doctor should be doing is trying to come up with a routine and a strategy that saves as much time as possible whilst addressing your concerns. And I suppose I'm just thinking acutely about how I run my clinics. I spend a very short period at the beginning proving to the patient that I know what's going on. It doesn't have to be very long, but I think the patient likes to know that I know what disease they've got and what's happened before. And that, so just because trust is so important, you want the patient to recognize that you're a sensible doctor who knows about them. And then I actually spend a little bit of time doing context. So what do you do for a living, or what did you do for a living, and who's with you at home? I tend to ask. So just to kind of get a tiny bit of context. And then maybe I do go into the nuts and bolts of hepatology care. But maybe what we should be doing, Jose, is moving the patient agenda much more towards the top of the consultation and letting that inform things. But I do think all of this changes as you go through your career as a doctor. So as a junior doctor, you are focused on, are you going to bleed from your varices? Have you got hepatocellular carcinoma? Are we optimizing your ascites? Have we got the diagnosis? Do you need a liver biopsy? They're very much the focus. But as you become more and more senior and experienced, yes, obviously you're doing all of that stuff, but you're quicker and more adept at bringing in the patient voice. And that's why communication, patient voice, patient advocacy, sessions like this at EASL at Congress are so important, because it means that you instill in very junior doctors a blueprint for how to run a successful and patient-centered consultation.
Yeah, and it's also a matter of language, or how do the questions. I met the doctor and he said, what do you expect from me? So, well, a cure. Instead of, and I know that his intention was to ask me, what can I do for you? That is completely something else. And a lot of doctors are not aware that they ask the wrong questions, and they have the intention to do it right. But maybe something like that, to realize what are you really telling. And if you leave the room, very often doctors say, well, if something's wrong, give me a call. And say, if you have a call yourself, because you're never there, or people are afraid to give a call to you because you're so busy. Doctors are always busy. That's the intention they have. And so that there is a lot of, just some small steps. Doesn't cost money, doesn't cost time. It's only awareness, how they act in the room. And it's not that difficult to make the patients much more happier.
I'm just going to jump in there because I think the discussion that you've both answered and posed questions with answers that are really practical for physicians in the clinic. Jose, at the beginning you were talking, this is a really important relationship for a patient. It's like speed dating. You've only got a few minutes and you've got to nail it. And because you're going to face the future relationship you have with one of the biggest people in your lives for the next 20 or 30 years, particularly in the speciality of hepatology, on a 4 or 5 minute interaction. And Tom, you detailed how you can try and get that when you first meet a patient for the first time. There is certainly a potential role for allied health to do some pre-counselling, what are your biggest concerns when you see, let's make that easier, let's make that fruitful interaction? Is it something to solve some of those challenges? Because nurse specialists, nurse teams around hepatology are skilled. Do they need to preempt and pre-prep? Would that be beneficial? It certainly works very well in the cirrhosis program about keeping that maintenance, because you do get to know people personally. That was something that came out what you were discussing there. Is there an effort to pre-prep a specialist clinic to know a little bit more? Are you coming with somebody? What are the difficulties if you're getting here? Would that be, how can we facilitate? And I know everyone listening to this is going to scream, we just don't have time. But actually it's about how you spend quality time in healthcare to improve the quality of care, reducing load in the future in these areas. Is that something that can help navigate the challenges that you were describing?
Yes. I think so, Louise, definitely. So I think you have to build a multidisciplinary team around the liver patient. We've got an excellent nurse-led service of hepatology specialist nurses. The way I think in which they're operating well and best at the moment is actually post-clinic. So it's delivering the information in clinic, which can be information overload. And then they'll go home and the patient will process things, and then we'll have follow-up questions or follow-up queries or follow-up, do I take my medicine then, or am I meant to be halving the medication, or when am I next coming in for a drain, or all this kind of thing. So actually there's a lot of picking up the pieces from clinic in terms of information transfer that we're finding nurses are incredibly helpful for. In terms of preparing for clinic and establishing patient concerns pre-clinic for the doctor to address, I don't think that's happening at the moment very much. It may be happening a little bit more elsewhere, particularly in the States where they've got lots more IT systems where doctors and patients are communicating, electronically a lot more. But certainly in the UK, there's not much pre-clinic planning, but certainly after clinic for questions and helpline advice, basically, it's been very, very useful.
Well, not every country has really hepatology nurses. In the Netherlands, only a handful. And it's growing now, but it's always an excellent model. And I'm very jealous on the UK, because the nurses play there such an important role. And it's coming now, but if the nurses are not there, what to do?
I think one of the tools to make an effective discussion between patient and physician and any healthcare giver is the issue of motivational interview. And I think every physician should learn the principles of motivational interview. It's so simple, and it's a little bit time consuming. It's true, but with some practice, you can also do at least some of it in a couple of minutes. And it's really about asking open questions about how the patient feels about your recommendation. What are the barriers for him to manage the disease? What are the things that the factors that support him? Family support, or does he need any other support? And I think with a couple of questions in each visit, it doesn't have to be very long, but open questions, you can learn so much about the things that would really help the patient to manage the disease better. And it is also very much true with regard to lifestyle modification. So it's not only diet, it's physical activity, of course, but it's also alcohol consumption or even better management of the medications. So the understanding how he manages these things, how he feels about it, what are the challenges, what are the factors that can support success in these matters. I think these are really important questions. And one of the most important things is not to criticize, because if we start to criticize the patients, for example, if they drink alcohol where we told them not to drink, or if they take some food supplements they shouldn't and they're afraid to tell us about it because we told them not to take anything, right, without asking our advice. So sometimes they tend to hide it, and that's not the way to communicate best with the patient. So I think really open questions and not criticize. That's a very important issue in better communication between patient and physician.
Yeah, I completely agree, Shira. So much of what we do is about motivating, isn't it? It's all about trying to infuse the patient to take control of lifestyle factors. It's all about motivating. And as clinicians, we quite like frameworks in which to do that. And I think training in brief interventions for alcohol alcohol and for lifestyle, I think is a really powerful but probably underutilized in medical education, I think.
Yeah, and another thing is I think that Jose mentioned that physicians are unaware how much the physician is important to the patient.
Yeah.
What a huge role the physician has in patient lives. Studies show that the person that gives the highest motivation for a patient to have a lifestyle modification is the physician.
Really? Okay.
They listen to their physicians. They trust them. So the greatest opportunity to create a motivation for lifestyle modification is the interaction between the physician and the patient. This is the greatest opportunity, which is often missed.
It helps so much if a doctor say to you, hey, I'm here to help you, and we have to do it together. That is already so helpful. And then the attitude, well, I have here, a solution for you, but you have to listen. And if you don't do it, I don't know what to do anymore. So that's such a difference if it's an open attitude, like, hey, I'm here to help you. That's part of my job. But I think that young doctors are more aware of that. But maybe that's my impression because I met a lot of young doctors. So I am hopeful. But yeah.
I want to reemphasize the importance of tailored care and tailored treatment and say that physicians need to recognize that every patient is different. And for one, 10,000 steps is not enough. And another 10,000 steps is a hell of a lot. And so maybe for that patient, 1,000 steps to start with and then incrementally work their way up. And from a patient's perspective, it would probably be a lot less frustrating if they knew that the physician recognized them as an individual and the challenges that they have.
I think you're right.
You need to start it with the question. You need to start how many steps you can do, actually. So you don't say you need to do 10,000. That's motivational interview. You start with a question, how much you think you can do. And then you move forward.
Yeah, and keep it simple. I had once a phone call with a lady, she had to lose weight and do more exercise. And she said, I hate exercise. I hate it. What can I do? I hate everything. And I said, okay, you hate everything, then the most easiest way is just walking, because that's cheap and easy. But what you do is make 100 steps. Put your hand on your liver and say, hey, I'm doing this for you. Are you happy now? And then I said, and then the next one. And then she started to laugh. I said, really do that, because it will help you. And then later, a couple of months later, she phoned me. She said, I did that. I really was talking to my liver, and it helped me just to stop. Like, hey, are you happy now? And I do it for you. And it's so simple and it's funny, but it made her walking. And now she told me that she is walking now the 10,000 steps a day. And she started with 100.
That's great.
And that's exactly the key, Jose. It's small and often. And it's getting the quick wins to start that snowball going. I don't use the term exercise. I try and use the term movement, more physical movement, because not everybody, exercise puts the fear of God into most people, because exactly that phrase, they just envisage a gym, they envisage running, they envisage all of the hard work that we see all of the time. But jiggling about a bit in your kitchen to a bit of nice music is more movement. Preparing a nice new meal that Shira's advised with a little bit more exercise, bringing your cans down or doing things, it can be made exactly like you described, fun. And once people find fun,
karaoke singing too, right?
Yeah, karaoke is wonderful. Yeah,
It's crucial.
although he doesn't do anything.
absolutely, motivation.
Yeah, but you don't have to go to the Olympics, and you don't have to play football in the first team. That's what I always say to men. What do you like? What did you do when you were young? Yeah, I play football. So every club has also teams now for older people. You have even teams where you're not allowed to run, but just walk. Go to there, and the only thing you have to take care of, that is the third part of the game, that you don't drink beer, because then it's a waste of your other two halves of the game. And then you make them realize, because people always think, well, I have to go to the gym and they have to run 10 miles, and just start with half a mile and then you will see where it goes. So
You touch on a really good point there, Jose. There are lots of things like that, but the food and the awareness around all of those establishments, it's high sugar, high fat, it's very rarely healthy. I've done some work with football clubs. Football players themselves, very healthy. The minute they give up the exercise, they keep the calories up, they fatten up. but the staff around, because they're eating the wrong things, and that's all that's provided, pasties, pies, pizzas, it's an environment. Shira, I'm sure you'd share that thing. The environment that they're put into to do the exercise, counterintuitive sometimes to doing the exercise, because they're just put at risk.
I have a question to Tom about it. Tom, we live in a toxic, obesogenic environment, and we tell the patients to eat healthy food, which is also more expensive. Do you get to discuss it with patients? Do you get to discuss the issue of the environment and how they can manage their eating in this environment, and also about socioeconomic factors like some of the foods? Because some of my patients tell me, what you recommend is too expensive for me. I get to hear that a lot.
Yeah, that's a really good point. So, I mean, the first part of your question is, yes, we're addressing diet quite rigorously, and we're explaining about the environmental factors driving their liver disease. We also, listening to your conversation, we always emphasize it's never too late for these changes as well. Some patients think, they've got advanced liver disease, or, they're this age, or they've had this disease for so long. But actually, it's important to emphasize to these patients it's never too late to implement these healthy lifestyles. And so diet, we do tackle quite robustly. But the second part of your question about socioeconomic status and expensive foods, I don't think we tackle enough. But I am noticing a lot of conferences at the moment, food insecurity is becoming much more topical. There's a lot more talks and a lot more research emphasis on understanding the socioeconomic drivers of poor diet and how we can deliver healthy diets in a way that isn't too expensive. But actually, I think it's lagging behind. I think the field has been very focused on establishing what's healthy and what's not and delivering that message. And actually, probably in the years ahead, we need to be much more nuanced about how we tailor that dietary advice according to the patient's phenotype, but also according to the patient's socioeconomic status. Are you managing to do that, Shira, in your practice? Are you taking account of these socioeconomic factors?
Yeah, actually, I got more sensitive to this topic than I was in the past. I've always heard from patients that some of the foods that I recommend, like fish and walnuts and olive oil, are too expensive for them. So it's nothing new. But I think in the past years, it became worse, and I get more sensitive to this topic of food insecurity and socioeconomic inequities. And then I try to think with a patient what kind of diet we can tailor that would be less expensive. For example, if they reduce their sugar beverages consumption, they actually save money, right? So there's no excuse to continue having sugar beverages. But also trying to explain to them that you don't need to eat expensive food or food that takes a lot of time to cook. It can be very simple. It can be whole grain bread, low-fat cheese, some vegetables and eggs, and you have the healthiest meal, right? So you don't have to do anything too expensive or too complicated cooking. You don't have to spend hours in the kitchen to actually have a very healthy meal. So what I'm trying to do more and more is to simplify my recommendations.
Yeah, that's really helpful. I think we need to be doing this. I need to be doing this more, particularly because we know that social isolation and unemployment are big drivers, both of liver disease, but also of unmet needs. So if you look at patients in the clinic, 80% of patients have got unmet needs in the liver clinic. That's nice data showing that. But that population is enriched with those that are unemployed or socially isolated. And then if the information you're then delivering is useless to them because they can't afford the food in which you're recommending, then it just becomes a futile circle. So I think this has been that's helpful, Shira, for us to think about as clinicians going into these clinics about how we tailor our advice based on socioeconomic background.
Yeah, and what I see a lot is when you look at diets, and I've never found a diet just with the vegetables and fruit of the season, because that's always cheaper. And when I was young, we didn't have all those prepared and already cut vegetables in the shops. It was very basic food. And I discussed that with some lady on my own age, and she said, well, you're true. It doesn't exist, all those sauces and other things you can add to your food. And she skipped those things. She just thought, well, how did my mom cook? With less salt. That's true, because they used a lot of salt when I was young. And it helped her. So it's just, I think we have just go back to the basics.
Yeah. go back to basic.
I wanted to ask Tom and Shira, and Tom had mentioned isolation. Do you recognize mental health, because behavioral support is incredibly important for treatment now? Do you recognize in a patient when you're in front of them that they may be suffering from some mental struggles?
Yeah, it's a really good point. I mean, I like looking at the big patient-reported outcomes data, actually, because I think it can feed right down into the individual consultation. So when you ask a huge group of patients, thousands and thousands of patients, what we can do better, when you ask them that question, what we can do better in clinic, they say three things. They say better education and information, which we've touched on. They say reduce public stigma, which we've touched on, but they also say better psychosocial support. And the reason is because we know that patients with psychosocial issues or mental health issues, we know they have a high burden of unmet needs. And we also know that they get bad liver disease. So I think the first thing is recognizing the data showing that it's a really big issue in our clinics. And then to come back to your point, Michael, about are we recognizing it? I think we're quite good. I think we're quite good at screening, of probing, and then of signposting to services, which is in the UK is nearly always through primary care, nearly always through the GP. And actually cultivating that relationship between the hospital doctor and the GP is pivotal in helping access to mental care support. But there is so much mental health, particularly in the alcohol-related clinics, and the Hep C clinics, but increasingly in the MASL clinic, which is probably been under recognized. But we do try our best to signpost to services when we see it. Shira, I don't know if you agree.
No, I completely agree. I try to ask very gently. I don't want to be too invasive with the questions. So I look at the patient in the eyes and ask, how is your mood recently?
Yeah.
Or do you sleep well? How is your sleep, for example? So like a very delicate questions to see whether the patient is interested in opening this topic. Usually they are very interested to talk. They just waited for someone to ask. And it's also very much related to obesity. For example, if I see a very strange weight gain, like the weight jumps up and I realize there could be some stress related to eating, or it's less common, but also a very large weight reduction can also be something that has to be with a psychological state, or we start looking for other things like HCC surveillance, but that's another issue. But it's really important. I do ask the patients how they feel, how they sleep, how is their mood. Of course, it's very much related to the way they eat. There's a lot of emotional eating. So it's very much related to my work.
So can I ask, there was a discussion in the room about engaging more with people who've got lived experience from different areas. Now, having in the past operated and run and facilitated patient groups, probably more in viral hepatitis or in psychiatry, do we have, or are people aware of muzzled patient groups within hospital settings, or are they just liver specific? If you run one, for example, Tom or Michael, is it something that's common in Canada that you get patient support groups just run in hospital for muzzles, which is now a growing population, and obviously obesity and stigma comes strongly into some of those?
Yeah, so we do have muzzle-specific support groups in the UK. Their role is very much highlighting patient needs, highlighting that there are unmet needs. But the lived experience thing, and correct me if I'm wrong as a group, but the lived experience side of things, where I've seen this best is within the viral hepatitis space, which is people that have had really tough lives, who have overcome lots of barriers, who have got treatment for their hepatitis C, and then are now becoming integrated within the care pathway for outreach and to target patients and to help recruit patients into eradication. And so they're really using patients with lived experience to actually become part of care delivery. And that's really powerful within the viral hepatitis space. But I don't think we're seeing that yet within the MASL space. For example, patients that have had loads of metabolic risk factors, have done really well to lose weight, have overcome lots of challenges, have seen their liver disease get much better, have adopted their healthy lifestyle. I'm not seeing those patients yet be integrated back into the healthcare service as a motivation and inspiration for other patients in the clinic. And I think the viral hepatitis model is so powerful and so persuasive that we should probably be taking really, role model patients and making them more visible for our MASL patients.
That's important because we can start at a level of higher start because of that lived experience of viral hepatitis. And you're right. And it was something that was in the room along with the questions of stigma. And I think Donna Cryer got up and talked about the fact of motivational patients who've been there, done that, got the t-shirt. So not just focusing on that, but that whole look at somebody who's done it, that exactly what you've described there.
I remember that conversation in the room, a patient herself saying we should be wheeling out patients that are really strong role models with big presence either on social media or good speakers. And, again, it plays into the ability to motivate. And actually, that was kind of a new thing in my mind about it's not just involving patients in workshops in side rooms to inform grants and to inform, policy. It's actually being much more vocal at having a role in care by motivating their peers.
Michael, you're obviously strongly involved with GLI and that whole motivational, and a lot of your videos are highly motivational, as well as fun and informative and education. And how much feedback do you get from your patient community on how that motivates them to take the next step? You've seen some of the comments on the work that you're doing at the moment being 24/7 monitored.
I'm getting actually a lot of people writing and saying that it helps them with some of their food choices that they're making more than you think. A lot of people are just sending me comments. Sometimes I'm getting suggestions of what to eat, and I'm throwing those in when I can without killing myself when I know it's not the right thing to choose. But I agree with what Tom said about the Hep C model, because I was very involved at the very beginning after non-A, non-B when Hep C first started, monotherapy, and patient support groups were quite important when in a focused area. I don't think in Canada for sure they're not at a massive isolated support group. I've been doing I've done 2 and I'm planning to do more across the country, metabolic community education sessions where I bring in a hepatologist and a nurse clinician and a patient and talk about how type 2 diabetes, obesity, and liver disease are all so closely related, and that you can help to work on one and you're working on all of them. And so I think in the short term, that metabolic approach, I know Shira believes in that as well, for sure. That might be a better way to bring in some of the people in some of those other circles in the Venn diagram of metabolic comorbidities.
I also believe in holistic approach. So we don't treat an organ, we treat a person. So we treat liver disease, but all other diseases, we treat mental health. We need to be sensitive to socioeconomic status and so on and on. I mean, a holistic approach, I think this is the approach we should use nowadays.
And that's why MASH is tricky for lots of reasons, both clinically, but also from addressing patient needs, is because it is so multi-systemic with so many moving parts, being managed often by a liver doctor, which is only one tiny portion of the pathogenesis of the condition. So I actually think MASH patients have it tough for lots of reasons, but because there's so much to tackle, they're at high chance of having their needs unmet. So I completely agree with you. The more holistic and the more multidisciplinary approach to these patients, the more chance we have of really making a difference to quality of life.
Yeah. And interestingly enough, that brings us full circle to that full interaction with the patient at the beginning and knowing about them, finding more about them, because you're the most powerful person in their life, apart from their partners and their family, for the next 20, 30 years, going back to what Jose is saying. So those extra few minutes, really digging down and finding out more about your patient, gives you that better base for the holistic approach. So that's a nice place to sum up, because we are at the top of the hour here and it's been a great discussion. But I'm going to ask each of you, if you had to take one part away from the discussion today and for the challenges that patients face, what would be your one tip to the physicians listening, and where to take their patient care and how to help break down those barriers that are currently faced? Brave one, go first.
My take-home message really is that you shouldn't just assume that addressing the patient's needs is going to be automatic as part of your consultation. You have to really be focused on integrating that within your consultation. And so turning off the computer screen, giving dedicated face-to-face time and space, and allowing that space in your consultation to allow the patient to, voice their concerns is paramount. You can't just assume that's going to happen. You need to consciously build that into your clinic model. Do you agree, Jose?
I agree with you completely. I would add to that partnership. We should have shared goals, shared decisions about how to do the treatment, how to move on. set realistic goals together. It's a partnership. That's what it is.
I would say it would be great if physicians could actually and honestly be curious about the needs of that particular patient in front of them and to ask because they actually really want to know, not just because it's the next patient and they're trying to get through the patient stream.
Well, this is not surprisingly probably because I come back to my mantra. Just do it once a year. Ask how it affects people's life. And because then you will get a lot of information as doctor and the patient will be happy that you asked that.
Wonderful discussion. Thank you. I'm going to jump on something that Shira said in that as one of my take-homes now, I suppose, is this setting goals. Healthcare is very good at setting goals, measurable. So we do that whole model all of the time. The patient doesn't only have to be the person writing the goals. The joint goal setting is what are you going to do for me, doctor, and I'm going to do as well. So there can be, and I think that was a beautiful thing that you said there, we can set dual goals of what we're going to achieve together and have that reviewed with the question of how did that affect your liver, affect you this time? How did we achieve our goals that we've set together? And we walk together hand in hand as a partnership. And I think if that helped break down those barriers, then it was a fantastic session that was done. There were lots of things suggested. I've listened with avid intent to the discussion going on. Didn't feel any need to interrupt because it flowed and you answered the questions that were posed. And I think that's the natural place to go. The answers sometimes can be very simple, but we do need to, as you've described today, sometimes think out of the box. And I love stretching healthcare beyond those boxes. So thank you all for joining me. And it was a wonderful session. And for anybody who has access to the EASL platform, you can review the entire session and watch it and have a look at the other speakers who were amazing as well, discussing the stigma, what's happening in cancer, viral hepatitis, and things like that. And also, if you wanted to attend another session on the diet, Michael and Shira are the dream team because they did the sellout session for the diet, which led into the new practice guidelines, which, of course, Shira, you are part of the development of them. So the dream team, presenters and co-hosts for EASL, thank you very much. Michael, Shira, Jose and Tom, thank you very much for joining us. And I hope you've enjoyed your first session being official surfers now with a few secrets, and karaoke at the next conference we're all at is certainly on the list for Tom. But thank you very much for your time and it's been a pleasure.
Thank you.
This week's question of the week is sponsored by Madrigal Pharmaceuticals.
And here's our question of the week. This week's episode talks extensively about changes in perspective and actual verbiage that will improve communication between provider and patient. Given that it's unlikely that health systems can afford to increase average visit time dramatically, what structural or educational changes do you anticipate will improve provider-patient communication significantly? Will these changes require more from the provider or more from the patient?
And now for the Season 5, Episode 23 Business Report.
Slava Ukraini, glory to Ukraine, Heroyam Slava, glory to heroes, and also Am Yisrael Chai, the people of Israel live. Only one comment this week. As we in the U.S. prepare for next week's Republican convention, we can only hope that the tone and substance of the convention and of the election that follows do not give encouragement to the enemies of democracy and that over time, the American people reject extreme solutions. With that said, let's remember and respect the brave Ukrainian fighters and residents, remember and wish for the safe and speedy return of the many remaining Israeli hostages, and remember and pray for the safety of the Gazan residents whose needs are poorly served by their government's approach to the situation. Heroyam Slava, glory to heroes, and also Am Yisrael Chai, people of Israel live.
Our month of lessons from the EASL Congress concludes within the next 2 weeks.
Thanks to Louise for her excellent hosting and to Shira, Mike, Jose, and Tom for a fantastic and stimulating discussion this week. I was sad to miss it, but found sources of inspiration, reflection, and occasionally frustration in the actual discussion, which is the kind of thing we hope to achieve each week on SurfingMASH Tsunami. We're working on a session addressing NIT issues from the EASL Congress either for next week or the week after. Keep an eye out for online or email messages and notes for the live recording.
Hey, Indonesia, thanks.
For the most part, I've stopped talking about our pod status reports because the story stays roughly the same each week. Somewhere between 6 and 10 countries placing us in their top 250 medical, occasionally someone putting us in their top 250 health and wellness, which is a tougher standard. This week is different. We spent 2 days at the number 1 medical and most of the week in the top 3 medical in Indonesia, a country where we've never seen such robust results before. Not only that, but we spent 3 days in the top 250 all-topic podcasts there, which virtually never happens. So to our listeners in Indonesia, let me say, terima kasih banyak.
Office hours continue next Wednesday, July 17th at 11 o'clock Eastern U.S. time.
Okay, we started office hours this week. Thanks to the two friends who showed up briefly to wish me well during our initial session on Wednesday. Our next office hour will be Wednesday, July 17th at 11 a.m. Eastern Time, 5 p.m. in Central Europe, 4 p.m. in the British time zone, 10 o'clock in the morning in Chicago in the Central U.S. We'll publish the Google Meet link for these in next Monday's newsletter and every week thereafter, and, starting next week, include a question I'd love to discuss with any and all interested parties.
This week's Vault comes from Shira Zelber-Sagi's last appearance on SurfingMASH.
Shira and Ken Kusi joined the surfers during U.S. Thanksgiving Week 2022 to discuss strategies for improving patient self-management and for providers to support this effort. It's a fascinating counterpoint to some of today's episode and focuses more on the advice a physician gives than how to structure the dialogue, which is different from this week. So that's it for this week. I want to thank Louise for stepping in so ably and the rest of the team, Mike, Eric, and Steve, as we move on from the EASL Congress to the rest of MASH World. I particularly want to thank our guests, Shira, Mike, Jose, Tom, who are fantastic. Please take a listen to our question of the week and, of course, reply. If you're a LinkedIn follower, check your email or messages for an invitation to subscribe to our weekly piece and for how to access my weekly office hour, 11 a.m. Wednesdays, Eastern U.S. time. We're still working on next week, which we hope will look at NIT issues related to the EASL Congress. Until then, stay safe, surf on. We'll see you on the podcast. Bye-bye now.
Have any questions for the surfers? You can send them to questions@surfingmash.com and we will answer on the podcast or website. Your question might even wind up being the question of the week.